안녕하십니까?
Hello, I'm Dr. Sun Young-hee from Ijeon Dental Office. This is the fourth lecture of medications, and we are going to look at adverse drug reactions. Drugs have mechanism and they work, but always are accompanied with undesired adverse effects. So it is important to know how to manage such adverse effects. Drug side effects. Definition. A side effect is an undesirable secondary effect that occurs in addition to the desired therapeutic effect of a drug. Usually they have risks. They are called side effects. But if you look into them, there are many different types. Side effects are all those unwanted or unintended effects when medication is administered according to normal dosing. When we say side effects, they usually refer to adverse drug reactions, ADR in short. Adverse drug reactions are unintended reactions with the risks during normal administration or use of a drug, and it cannot be ruled out it is caused by the drug. These are what we usually call side effects, which is too broad. So specifically, adverse drug reaction is more accurate. Next, adverse events, which are undesirable and unintended signs or diseases that occur during the use of a drug, and the causality doesn't have to be established. These are the events that occur during the use of a drug. If you look at the scope of the meaning, side effects have the broadest scope, followed by adverse events, and the adverse drug reactions are a subset of adverse events. Adverse drug reactions are reactions that are adverse and related to the use of a drug. What about ADRs in Korea? How are they classified? The first ADR type is NSAIDs, which is the most frequent one, followed by anti-cancer drugs, antibiotics, contrast media, and pseudo-opioids. So ADRs from NSAIDs is the biggest. NSAIDs are routinely used, and we need to look at ADR in terms of NSAIDs, followed by antibiotics. This is a pharmacological classification of adverse drug reactions. Type A is predictable adverse reactions, overdose, side effects, drug-drug interaction, secondary or indirect effects. So predictable reactions. Type B, unpredictable reactions, intolerance, idiosyncratic reactions, hypersensitivity, and pseudo-allergic reactions. When adverse drug reactions happen, how can we determine them? They're based on causality, incidence rate, and maximum strength. For causality determination of ADR, certain the reaction followed a reasonable temporal sequence after a drug is administered, could not be explained by other drugs or diseases, showed a reasonable response on withdrawing the drug, was confirmed and reappeared on re-exposure when necessary phenomenally and pharmacologically. Probable, likely. Possible, unlikely, unclassified. So the causality, the relation to the drug is determined using this chart. 10 items are listed. Scales are present, absent, not known. If the scale is 9 or more, definite, 5 to 8, probable, 1 to 4, possible, 0 or below, doubtful. This is how causality is assessed. Naranjo probability and other causality assessment methods are available. I don't want to go over that. Next, incidence determination. We need to be paying attention to this. If you look at monograph, we encounter these expressions quite a lot. How many occurrences do they mean? Very common means, very frequent means 10% or more. Incidence rate. Common means 1 to 10%. Uncommon means 0.1 to 1%. Rare, 0.01 to 0.1%. Very rare means less than 0.01%. So if you look at monograph, these expressions are indicated, and these are based on the determination of occurrences. Next, the determination of the strength of ADRs, mild, moderate, and severe. So these are how ADRs are determined. Frequency of ADR. NSAID shows the highest frequency. As you can see here, in overseas countries also, the most frequency is observed from NSAIDs, antibiotics, and anticonvulsants. 20% of ADRs are from NSAIDs and 13% from antibiotics. Symptoms. The most frequent symptom is skin lesions, followed by GI trouble. Let's look at ADR of antibiotics. Shock, hypersensitivity, GI trouble, hematologic problem, CNS problem, etc. Amoxicillin shows the highest frequent ADRs, followed by cephalosporin, generation 1, 2, and 3. Shock, hypersensitivity, GI trouble happen quite frequently, and the rest happen rarely. As for antibiotics, hypersensitivity is a dreadful one. Adverse drug reactions are shock and hypersensitivity, including anaphylaxis. 80 to 90% of the symptoms appear on the skin, including itchiness, hives, redness, and intraoral swelling. 70% respiratory, including stuffy nose, runny nose, sneezing, and difficulty in breathing, and wheezing too. GI trouble, 30 to 45%, nausea, vomiting, stomachache, and diarrhea. Shock or hypersensitivity can be diagnosed early when there's skin symptoms within minutes to hours with respiratory symptoms. After exposure to the drug, 2 or more long-term symptoms of skin, respiratory, cardiovascular collapse, or GI symptoms, the acute symptoms, or when suddenly blood pressure drops after exposure to known inducers. Diagnosis would be based on these. To prevent them, we need to do skin tests and history taking before administering antibiotics. So when they occur, how can we manage them? In the past, when diagnosis was not clear, antihistamine or corticosteroid were administered first. Now it's a little bit different. Even though diagnosis is not clear, epinephrine IM is used first, 1 to 1,000, 0.3 to 0.5 milliliter. That is, 0.3 to 0.5 milligram is used. 0.01 milligram per kg is used for children. Before intravenous route is secured, this can be administered first, and if necessary, it can be administered 5 to 15-minute intervals. Epinephrine IM should be administered first. What is important is the patient should be lying down. You should not make them stand up. If they stand up abruptly, there are reports that death can occur, so they need to be lying down, not sitting up. After the improvement of symptoms following emergency treatment, secondary reactions can happen, so you need to call 911 to refer them to the general hospital. In this case, epinephrine should be administered first. As I said before, so for emergency, we can use EpiPen or Jext. So they are available. The problem is both of them have very short shelf life. So if they are expired, you need to buy them again. They can be administered over the clothing of a patient, and they are usually given to the femur. They are auto-injected on the femur. You need to have one of them in your dental office. GI trouble due to antibiotics include nausea, vomiting, diarrhea. We heard pseudomembranous colitis a lot at our dental school days. GI trouble would be caused by macrolide, then beta-lactam, like augmentin. However, most oral antibiotics have nothing to do with diarrhea, even though they say diarrhea happens after taking antibiotics. So what I want to say is antibiotics do not cause diarrhea. GI symptoms caused by antibiotics cannot be resolved with antacid or intestinal cleansers. You know, pseudomembranous colitis is caused by Clostridium difficile. They make up 15 to 25% of antibiotics-related diarrhea. Age is a risk factor. As you go older, the reaction happens more. Concomitant administration of antibiotics and PPI are risk factors. PPI stands for proton pump inhibitor. Incidence rate is important. I want to say that incidence rate in Korea is 67.5 per 100,000 people. That's 0.067%. We will hardly see such cases. The incidence rate is high among hospitalized patients but very low among ambulatory patients. They are treated with vancomycin or metronidazole. This is important as the death rate is high, but you just need to know that something like this exists. If you treat hospitalized patients, you need to pay attention to this. Otherwise, this can be something you don't need to worry about. I talked about adverse drug reactions of antibiotics. An important thing is you don't need to be concerned about GI symptoms related to antibiotics. Next, NSAIDs. ADR of NSAIDs. This is important. There are many adverse reactions we experience. I said NSAID is aspirin-like drugs. There are so many different types. Adverse drug reactions of NSAIDs are so many: GI, hepatic, renal, hematologic, cutaneous, respiratory, and CNS. But as I said before, these are from inhibition of COX-1. The most frequently occurring one would be GI trouble, like indigestion, gastroesophageal reflux, erosion, hepatic ulcer, GI hemorrhage, and perforation. These can be critical. The most frequent ADRs of NSAIDs: abdominal pain, heartburn, sense of distension, indigestion, those make up 40%. GI bleeding, perforation, occlusion make up 1 to 1.5%. The rate is low, but when it occurs, the problem can be critical. Today, not only dental offices but other medical departments use NSAIDs quite a lot, so people are on long-term use of NSAIDs, increasing ADRs. So these are the risk factors: age, 60 or over, especially over 70. The incidence would go up. history of peptic ulcer and or GI bleeding, high dose NSAID, multiple NSAIDs, concomitant antiplatelet agent, concomitant steroids. GI trouble possibility would go up quite high, and the methicillin, ketorolac have extremely high ADRs, followed by naproxen, diclofenac, piroxicam, meloxicam, and ibuprofen in that order. So if you want NSAID that is safe, you need to go toward ibuprofen, but it has short half-life, so it should be taken frequently, as I said before. Management of ADRs, we need to assess patients based on these three risk factors: history of a previous GI ulcer, advanced age, and high dose of NSAID therapy, concurrent use of aspirin, corticosteroids, and anticoagulants. Risk factors are identified based on this. High risk, history of previous ulcer, moderate risk, 1 or 2 risk factors, low risk, no risk factors listed below. If NSAID causes ADR, to manage them, we need to think about whether we can suspend the use of NSAID. If the answer is yes, that should be suspended. Proton pump inhibitor, H2 antihistamine or misoprostol can be prescribed. If the answer is no, misoprostol can be prescribed, but PPI should be prescribed at the same time with the NSAID. If NSAID can be suspended, PPI and others can be prescribed. If NSAID cannot be suspended, PPI should be prescribed. ADR, prevention of ADR of NSAIDs. First choice is suspension of NSAID. NSAIDs should not be given, and patients need to be evaluated. If the patient has a high risk, no NSAIDs, celecoxib, rofecoxib, COX-2 inhibitor plus misoprostol or PPI can be used. For moderate risk, COX-2 inhibitor should be given, or NSAIDs plus misoprostol or PPI. For low risk, no prevention is required in prescribing NSAIDs. So when problems occur, we need to think about whether to suspend the drug or change the drug. I talked about PPI, misoprostol, H2 antihistamine. You know H2 antihistamine. You may not be familiar with the PPI and the misoprostol. To briefly explain it, misoprostol is a prostaglandin analog. So prostaglandin is administered. When used in a long run, there's a risk of diarrhea. So that's not used quite a lot. H2 antihistamine is used quite a lot. That inhibits the gastric acid secretion. H2 receptor is blocked. Standard dose is not sufficient, so 2 times the dose needs to be used to resolve ADRs. PPI stands for proton pump inhibitor. It stops the secretion of gastric acid, not just inhibiting. And the gastric acid secretion is stopped. Its effect is very good. However, there is a CDI risk when used for a long time. Clostridium difficile infection risk is quite high. But currently, proton pump inhibitor is used quite widely when you suspect A problem may occur from NSAIDs, or to prevent ADRs of NSAIDs, PPI needs to be prescribed. Most drug names ending with prazole would be PPI, such as omeprazole, esomeprazole. Next, COX-2 selective inhibitor. COX-2 only is inhibited. This lowers the peptic ulcer incidence rate 4 to 5 times, but it can cause CV-related ADRs, so it should not be used on cardiovascular disease patients. The principles of analgesic administration. It should be by mouth as much as possible so that patients can stop using it when they are okay. By clock, by letter, by individual, pain change and ADRs need to be evaluated to adjust the drug. We talked about adverse drug reactions of analgesics. They have a lot of ADRs because it's very easy to purchase as they are over-the-counter drugs. That's why there are a lot of ADRs associated with them. 30.8% of overdose patients are overdosing analgesics, and 11.2% of overdose deaths are coming from analgesics. It's not happening in Korea. Acetaminophen causes problems when used in overdose. This is happening in America. So in the United States, there are labels at the back of the bottles of drugs. FDA recommendation to seek help when a patient feels tightness in the chest. So labels are attached. When prescribing NSAIDs, AHA of the United States say this. In prescribing NSAIDs, you need to use the lowest effective dose and for the shortest period of time. That's what they're saying. I've talked about adverse drug reactions. All drugs have such reactions. I talked about ADRs of NSAIDs and antibiotics. Most of the adverse drug effects are from NSAIDs. To prevent misuse or abuse of NSAIDs, we need to understand how to manage them in prescribing NSAIDs to patients. So today we talked about adverse drug reactions. Thank you for your attention.